Hi, you guys. This is Jasmine, and today I'm going to be talking about nursing assessments in regards to cardiac lecture for children and infants and adolescents. Um, as nurses, we're going to have to know certain things we're going to have to look for and assess for to guide our standard of care. Now, when we're looking at fluid and nutrition, there's a few things that we're going to have to do. Okay, first and foremost, let me fix my screen. Okay, first and foremost, with fluid and nutrition, with nutrition, they need more calories. Why? Because they're growing. Okay, so that's why if we say a breastfeeding mom, she needs additional 500 calories. A child with a heart condition though needs more. Okay, so they may need way more food and fluid than a regular healthy term child. So one of the things we have to know is that cardiac child means increased calories. Another thing that we need to do is we need to assess their daily weights, okay? And when we weigh them daily, we need to make sure it's the same day daily and it's the same routine. You can't, it would be inaccurate and if you were to weigh a child after feeding one day and then you don't feed the child and then you just weigh them and then you feed them. That's a little inaccurate. And we also want to make sure we weigh diapers, I's and O's, because that can tell us if they're getting enough food or fluid in their body. Another thing we want to do is, allow the mom to breastfeed. If her baby is hooked up to an ICU monitor, if she can't breastfeed, encourage skin to skin, kangaroo care. Tell her she can breast pump, and they can add her milk into the nutritional needs of the baby. I know at Norton they do that a lot. So just you can't tell her she can't breastfeed. Okay, breast is good. Um, let me see. Yes. Oh, so let's say if she can't breastfeed, okay, there are things that we can do as nurses that we should expect in there. You are going to either get a NG tube, a Mickey button, or a PEG tube. So those are the three options. The one that is pretty interesting, the Mickey button is a device where it's sort of like a catheter, but it's really little. It's probably like this little expo marker tip right here. Maybe smaller. And how they actually do it is really cool. They'll insert it, put normal saline in it so it doesn't come out, and that's how they feed the baby. Now, does it pop out sometimes with strain and stress and eating? Yes, but it works. So those are the three things that you can do. And, you know, even if they can't breastfeed, let's say if a baby is experiencing really bad cardio and respiratory problems, you are definitely not going to force food down their throat, okay? They're not going to eat. But we have to some way get the baby to eat because if the baby does not eat, that baby will be considered, it will drastically, the condition will drastically decline. And then you have what's called I don't have enough space, so I'll write it down here. A failure to thrive baby. And we don't want that. Okay. And a good way of preventing that is to make sure that the nutritional needs of that infant are met. In regards to skin, so there are three things that can tell you whether or not that child is going into cardiac heart failure. If they have edema, more so specifically facial and orbital edema. Okay, so their face will swell, and then they get like these. Their eyes will start to swell horribly. Another symptom of whether or not someone is, or not someone, an infant is about to experience heart failure is cyanosis. and molting. Those are the three key evident signs of a child experiencing heart failure. Um, I just talked about the edema, but the cyanosis is blue lips, blue hands, blue feet. With cyanosis, also, there is a term that's associated with afterbirth cyanosis, which is completely normal. It's called acryosis or something like that, but that's normal after birth. It's you only the babies are only blue initially because it's like a shock to their body, and their lungs are trying to work now, and they have to breathe on their own. Of course, they're going to come out slightly blue because they haven't been using their lungs because they're immature, um, and they're non-functioning. Molting is if you ever work in hospice or long-term care, you can sort of tell the skin like just starts to change and become really pale, and that's how you know they're probably going to die soon. Hate to say it, but molting is an indication of impending death. Um, what else? Oh, and also, one of the other physical signs and symptoms of um, that are that a parent can see if they're not going through the appropriate growth and development stages. That that is a clear indication that, or if they have stunted growth, that's a clear indication that they have some type of blood or heart respiratory problems. And when you think about it, it makes sense because if a child is experiencing heart and lung problems, that means they're not getting the adequate nutrition that they should, so their cells are not going to grow. Their cells are going to be more focused on keeping the baby alive versus expelling all this energy to promote growth. Another indication of a physical sign and symptom of that we're going to be looking for is clubbing. Now, clubbing of the finger, so the baby's finger will look like this. So I'm gonna draw a little finger the best I can. Here's a nail bit. So a regular person's finger looks like this. Okay. A club finger looks like a club. That's a late sign. Okay. And the baby needs oxygen at that point if we notice that. We need to be ABCs immediately. Now the pulsations are either strong or weak. They don't change med surg to adults. The baby is still a human. It's still the same. Now, when we're listening to heart sounds, S1, S2, S3, S4, it's still very similar to med surg. So with S1 and S2, that is from your mitral and your tricuspid valves closing. Can't spell today. With your S3 and your S4 sounds, those are associated with murmurs, hypertension, and this is due to, or left ventricular dysfunction, and these have to do with your semilunar valves. Those semilunar valves are your aortic and your pulmonic. So those are not good. Okay, if you hear an S3 or S4 sound, it's not good. Keep doing your assessment, please. Did I miss anything with those? No. Okay, great. And also, it's associated with the left ventricular dysfunction in regards to fluid volume overload. That means your heart is working way too hard, or maybe your left ventricle is not pumping the blood out to your body systems, which can affect physical changes weak pulses, it can all just go downhill from there. Um, Now, when we're looking at respirations, um, we're looking for retractions. Lots of visible things that we're going to be looking for. Okay, so in terms of respirations and what we're looking for in an infant in particular, if they're having respiratory problems, we're going to see difficulty breathing, which is called dyspnea, and retractions. Substernal retractions are really big, is when they occur like up here, and they're really deep. I recommend you look at some YouTube videos, or when you're in clinical to try to get in your peds rotation, to look to see if so you can actually see them for yourself. Um, those are things we're looking for. Other things we're looking for, we're going to listen, obviously do our nursing assessment, and if they have exercise intolerance. If they're walking, you can see like toddlers are always on the go. And one of the indications of maybe they have some type of respiratory problem is if you hear them breathing and they're wheezing, or their breathing is irregular. They're using more of their muscles than they should be. With the CR monitor, a CR monitor is a cardiorespiratory monitor. It's also called an apnea bradycardia monitor. It just monitors bradycardia and apnea. Excuse me. With this monitor, um, how to put it on. So first of all, before you put this monitor on, there are three little sticky things. Um, and you have to clean it with alcohol. You have to make sure the uh, the white one is on the right side, and then the black one is on the left side, and then the green one is lateral on the abdomen. I forgot something in returns of. So, and with a CR monitor also, why would someone need a CR monitor? A CR monitor can show the doctor or the nurse a potentially life-threatening condition. Um, but the thing about it is that when you put those sticky things on, uh, a cardiac heart failure child, uh, they sweat a lot due to them overworking um, their bodies. So you have to make sure that you watch out for skin breakdown, especially with these CR monitors. Okay. So what is it is looking for apnea, and I just described how to put it on. But our interventions with this are to assess skin breakdown. Do not just rip it off the chest of the child. That's very painful. Just like you wouldn't rip off a band-aid. It's very painful. Just use your finger and slowly apply pressure and slowly try to separate the pad from the child. Diagnostic equipment that's used are ECGs, an echo, chest x-ray, cardiac MRI, Holter, pulse ox, and ventilator perfusion scan. Now, there's I'm going to go in detail on other like more detailed specified equipment. These few are just a few of the diagnostic equipment that they use in the hospital. An ECG is preferably that you do an ECG when the child is sleeping, and it's because it monitors heart function, and you can get a better accurate read if the child is laying down and sleep. An echo is used, it's a heart, it's an ultrasound that they can use to see the heart basically. And this is the first thing that they're going to use initially to assess heart function. A chest x-ray is, everyone knows what a chest x-ray is. But the good thing about the chest x-ray, because it is um, it can show bigger structures. The main structures in regards to breathing, you want to make sure you can see their diaphragm. You can see their diaphragm with this. And you can also see better cardiomegaly. Cardiomegaly is a swollen heart, like a big heart, due to the heart muscle overworking itself, which can lead to heart failure for children. A cardiac MRI. So there's a few things that people need to know about cardiac MRIs. First of all, they might need to be sedated, the child. Okay, they are in a tight space. They may be claustrophobic. No metal, no oxygen tanks. Also with the cardiac MRI, they're going to have to remain still for an hour. That's why they're going to sedate them. And if they're going to put them or sedate them, they have to be NPO. That's the most important thing, I think, because the metal thing and other stuff is pretty obvious. It's an MRI. Because if they turn that machine on, you will go straight into the machine. But the most important thing that I believe is about MRIs is that the child has to be NPO 4 to 6 hours before they give that to them, before they do that procedure. And the reason for that is because if they're not if they're not NPO, they can aspirate and then they can get stuff in their lungs and then you have a slew of other problems. A Holter monitor is a 24-hour monitoring device. Let's say the child comes in and, like, for example, I have a little girl um, that I know who has a Holter monitor, and it's a 24-hour monitor because she has fainting spells. So, but every time she goes to the hospital, uh, they don't see it. But when they made her take it home, they were able to see what's happening with her heart. So they wear that for 24 hours. The pulse ox, we already know it measures oxygen saturation in regards to blood. And the post perfusion scan too, they're going to have to be sedated and they're going to be NPO too. So I hope that all this stuff had helped you with our teacher's lecture, and I guess I'll see you next video. Bye.